Hello, I'm doing my presentation on the Helicobacter pylori infection. So the discovery of this disease is certainly a very fascinating one. It was discovered by Australian physician Dr. Barry Marshall and Australian pathologist Dr. Robin Warren in 1982. A year prior, these two guys met at Fremantle Hospital in Australia, and they both noticed an abnormal number of spiral-shaped bacteria in the guts of those with stomach ulcers and also those exhibiting gastritis, inflammation of the stomach. They both claimed that stomach ulcers were linked to H. pylori, contrary to the popular opinion at the time that these stomach ulcers were linked to environmental stress and not microbes. In order to prove the public wrong, Dr. Marshall famously drinks a culture of H. pylori and he gets stomach ulcers. And they finally believe him. And in 1994, the World Health Organization finally recognizes H. pylori as the causative agent for stomach ulcers and gastritis. And these two both win the Nobel Prize for Physiology in 2005. And here they are celebrating. All right, so the morphology of H. pylori, it's a gram-positive and bacillus bacteria. They're spiral-shaped and they resemble a corkscrew. This corkscrew shape helps it effectively burrow into the mucus that's on the outer membrane of our stomach lining. And its flagella arrangement is also unique. It's 3 to 7 flagella develop on one pole of the bacteria. Also, the bacteria is microaerophilic, meaning it prefers those lower doses of oxygen. Also, interestingly enough, H. pylori is also neutrophilic, meaning it prefers those pH ranges from 5 to 7.5. Yet, it thrives in the acidic stomach, which is really unusual, but we'll get into that later. H. pylori also produces urease. This urease enzyme facilitates the change of urea into ammonia and carbon dioxide. Also, on the outer membrane of H. pylori are these adhesin proteins, which allow for the bacteria to attach itself to epithelial cells of the stomach. All right, H. pylori adaptations. So even though H. pylori is a neutrophile, it is able to survive in the stomach because of this urease enzyme. Urease, like I said earlier, transforms urea into ammonia and carbon dioxide. Ammonia is actually a weak base, and this weak base allows for the H. pylori bacteria to raise the pH of its environment and create a suitable arrangement for it. Also, the motility allows for H. pylori to avoid contact with the digestive juices and move towards areas with higher pH. Also, it allows it to evade immune cells. Its mucus penetration is also very unique. Its corkscrew shape allows it to bury itself into the mucus like a drill, and it helps it be one of the few bacteria that actually can penetrate this layer. So it's in this very, very nice like safe zone where not very many probacteria can harm it. Also, its adhesins allow the bacteria to attach to stomach lining. This allows for the development of biofilms, and it makes it resistant to peristaltic movement, right? So that natural movement of the stomach as it's digesting, it's no longer going to move this guy because it's attached to the epithelial stomach cells. All right, so H. pylori usually exists as a chronic infection, which is really crazy. But what makes it so stealthy and in such a persistent infection is it can accumulate in biofilms. So there's certainly a strength in numbers here, right? As these guys are all acclimated together, there's bound to be at least one of them that is resistant to a certain antibiotic. And this allows them to be antibiotic resistant in some cases. Also, they have this very unique feature called antigenic variation. This switching of surface epitopes on adhesion proteins and lipopolysaccharides makes it very difficult for immune cells to recognize them. Also, we have immune suppression via regulatory T cells. So these regulatory T cells, shortened to Treg, are actually recruited during H. pylori infection, and they actually tell the body to stop attacking H. pylori, which is very unusual because you would think the body would want to attack it, but for the most part, H. pylori is pretty harmless until it starts secreting cytotoxins. Uh, and attacking H. pylori would honestly do more harm than good at its very um, not very dangerous stages. Um, it only starts to become dangerous when they start secreting these cytotoxins, so CAGA and VACA. CAGA uh, is a protein injected into the epithelial cells that disrupts signal pathways, inhibiting immune response, and it also causes a transformation in the cell structure itself, the epithelial cell structure, that is. So here we have healthy stomach epithelial cells, and here we have epithelial cells that are degraded by this cytotoxin associated gene A, right? The CAGA is causing it to become elongated and not as turbid as these guys. Um, Also, we have VACA, which is vacuolating cytotoxin A, and these are spores released by uh, H. pylori that infiltrate the the epithelial cell wall by creating vacuoles, and these vacuoles either swell or leave through channels, and they target the mitochondria, and the mitochondria prompts apoptosis. So the cells lyse, and when a lot of these cells lyse at a time, what do we get? We get these peptic ulcers. So this is how H. pylori actually causes these peptic ulcers. So tracing the steps here, here we have H. pylori penetrating the mucus layer and adhering to the epithelial cell. Here we have H. pylori utilizing urease. It's increasing the pH of its environment, making it more suitable. Here we have H. pylori accumulating into a biofilm. And here we have the degradation of epithelial cells with cytotoxins, with ammonia, and also uh, the degradation of the mucose layer is allowing for gastric enzymes, digestive juices to come in and come in contact with the epithelial cells, because this mucose layer actually usually protects it, but it's no longer here because the bacteria is creating mucinases, which are just enzymes that degrade the mucus and allow for the uh, the stomach juices to come in contact with the stomach lining. All right, transmission. So transmission of H. pylori could be because of food, mostly milk, meat, and vegetables. It can also be the gastro-oral route, which is through vomit, because there's a huge um, prevalence of H. pylori in vomit, obviously. The oral route is a route that's often debated by pathologists, and that is because um, it's hypothesized that the mouth is a reservoir for H. pylori, where no infection actually happens, but the bacteria kind of incubate there, so perhaps sneezing can cause it. There's also the fecal oral route. There's large traces of H. pylori in stool, and there's the possibility of contracting H. pylori through dogs, cats, and cattle. Here are the common symptoms of H. pylori. There's an ache in the stomach, and this stomach pain is usually worse when your stomach is empty. Nausea, loss of appetite, bloating, and unintentional weight loss. Another symptom that's not on here is actually bad breath, right? Because H. pylori creates ammonia, right, with urease, and this ammonia actually has a very pungent smell. Dr. Marshall's wife actually recalls Dr. Marshall having a bad breath when he consumes all that bacteria. Diagnosis. So there's multiple ways to diagnose H. pylori. The most common one is a breath test. So a patient swallows a pill containing urea. This urea is then consumed by the H. pylori, if it's there, and converts it into carbon dioxide, and that carbon dioxide is able to be recognized by its isotope. Um, its isotope. Also, stool tests are taken to determine the presence of H. pylori. So they take a look at someone's stool, take a sample of it, look at it under a microscope, and they determine whether or not there is H. pylori in there. Also, a biopsy. So here we see a doctor looking at a patient with an EGD. He can take a sample of it from the stomach, and he can examine it with the camera attached to the scope. So there's multiple different ways to test for H. pylori. All right, now treatment. It must be noted that H. pylori is usually not a deadly disease. It doesn't harm that many people. It is, in fact, it's estimated that 50% of people in the world actually have the disease. Obviously, it's going to be more prevalent in those developing countries as opposed to more wealthy nations. When H. pylori becomes cancerous, particularly with that oncoprotein CAGA, and when those stomach ulcers become especially painful, that's when you really need treatment. Otherwise, you're probably safe. So for treatment, typically we have antibiotics, usually two different types. Here we have amoxicillin and flagyl. Also, it's recommended that you take a proton pump inhibitor. It actually increases the pH of the stomach, which is very unusual because wouldn't that allow H. pylori to thrive better since it's a neutrophil? Well, it does, but the antibiotics work more effectively when it's not an acidic environment. Also, Pepto-Bismol eases the pain of stomach ulcers, and it protects the stomach lining from the outside environment. And after treatment, H. pylori rarely reinfects. After treatment, it doesn't really reinfect patients, and that's because we've already developed those antibodies. Awesome. And here are my sources. And here's a picture of H. pylori under a scanning electron microscope. Thanks for watching.